So I think we can start with the last session, and thank you to Andreas and Effis. I think we had an impressive day today where we saw the power of the community in immunology working together on the pandemic. We learned so much during this last year on specific T-cell and B-cell responses, also innate responses in different patient cohorts and different population groups. And I think this showed really the strengths of immunology, and this is something we will certainly take into the future discussions that we will have. The last session is adding other aspects on top of specific and innate immunity, and this is immune regulation and also more clinical aspects. And we start with Anne Puel, and we are very happy that you're here from Paris, from the Institut Imagine on sick kids. And immunodeficiencies in children is something that also came up as one of the major regulatory elements. And then autoantibodies came up as regulatory molecules that we might miss if we study immune responses. And we're very happy that you will be here by talking about acquired antiviral immunodeficiencies, which is something that's again showing us the importance of all the components of the immune system working together. So Anne, we're happy to have you here.
Thank you so much for the very kind introduction, and thank you for such a wonderful program up to now. So in the course of SARS-CoV-2, so most of us, we are developing either asymptomatic or post-symptomatic clinical features. However, approx 10% of the people, as you know, developed quite severe disease and severe or critical disease, and 1% of these people died following COVID-19. And so we were wondering what are the host factors that can explain this variability, and in particular, why some people develop critical or life-threatening disease. So we know that age, sex might be some factors, but we were looking for some other factors. So in that perspective, Jean-Laurent Casanova and Ellen Su at the NIH developed the COVID human genetic effort, trying to develop a huge consortium, and as you can see, with over 40 centers who participate to this study, to recruit patients, so people who were infected with SARS-CoV-2, either with asymptomatic or post-symptomatic disease, but also cases, severe cases, critical COVID, and also people who died following those infections. And we were wondering, are there any genetical or immunological determinants that are associated with severe COVID-19? And in particular, we first wondered if some of these people could have genetic defect that can be associated with severe disease. So, and as a first step, we were wondering, we focused on type 1 interferon pathway, because type 1 interferon has been shown in human to be very important to protect against severe viral disease. And here I'm just showing you the type 1 response pathway, and a number of genetic defects within this pathway have been associated with severe viral disease, including following HSV1, CMV, BOBV, varicella, or flu. And a number of patients with these inborn errors of type 1 immunity have been associated, have been found to be to develop a severe viral disease. So we wonder if inborn error of type 1 interferon could underlie critical COVID-19. And to make a very long story short, we indeed found 15 genetic disorders, shown here in red, 15 genetic disorders explaining approximately 1 to 5% of severe COVID-19 cases among adults, and it goes up to 10% of children. So this demonstrated that type 1 interferon are crucial to protect against severe COVID-19 pneumonia. At the same time, we know that autoantibodies neutralizing type 1 interferon exist in humans. So these neutralizing autoantibodies against type 1 interferon are known since the early 1980s, and were found in some patients who had been treated with recombinant interferon alpha or interferon beta. They were also described in a number of women, especially with lupus. And in other conditions, such as patients with thymoma or with some inborn errors of immunity, such as APS1 patient or APZ patient, almost 100 of these patients have neutralizing autoantibodies against type 1, or other patients with other inborn error of immunity. However, just before COVID, none of these patients, despite having high titers of neutralizing autoantibodies against type 1 interferon, were reported with any severe viral disease, except one patient reported in the early 80s who had high titers of neutralizing autoantibodies against interferon alpha, who suffered from disseminated varicella, and some few patients with a combined immunodeficiency due to heterozygous hypomorphic variant in RAG1 or RAG2, had severe, some unusual viral illnesses, but we didn't know if it was because they had neutralizing autoantibodies against type 1 interferon or because of their genetic defect. However, when COVID-19 came, 3 APS1 patients were reported in France to develop critical COVID-19 pneumonia. And as I told you, all patients with APS1 syndrome, all of them have high titers of neutralizing autoantibodies against type 1 interferon. Thus, we wondered if patients with severe or critical COVID-19 pneumonia could have autoantibodies neutralizing type 1 interferon. And so we recruited a cohort of almost 1,000 individuals with critical COVID-19 pneumonia. And as you can see here, in the patient with life-threatening COVID-19 pneumonia, we could detect high titers of autoantibodies against interferon alpha or omega. Whereas we couldn't see these autoantibodies in the asymptomatic infected individual. Few of the healthy control had also these autoantibodies. And in about 10% of the cohort of patients with life-threatening COVID-19 pneumonia, we detect neutralizing autoantibodies against type 1 interferon. Almost all of them were men, and approximately half of the patients were over the age of 65 years. And in a few patients, we had plasma before COVID-19 pneumonia, and they had already these autoantibodies. So we showed here that these autoantibodies were neutralizing by preventing STAT1 phosphorylation when the cells are incubated with the plasma from the patient. And we also look at the circulating interferon alpha during acute disease, either in patients with the neutralizing autoantibodies or in patients without these neutralizing autoantibodies. And here you can see that the patient who had neutralizing autoantibodies prevent the detection of type 1 interferon. We also assess the impact of these neutralizing autoantibodies in an in vitro system where we took UH7.5 cells that we infected with SARS-CoV-2 in the presence of 10% of plasma from LC donor in blue, in the presence of plasma from a patient with neutralizing autoantibodies against type 1 interferon or with a monoclonal antibody. And as you can see, when the cells were incubated with the plasma from the patient with neutralizing autoantibodies against type 1 interferon, we could see that the cells, the viral replication, and that this plasma prevent the protective effect of type 1 interferon. So altogether, this demonstrated that these autoantibodies against type 1 interferon blocked type 1 function both in vivo or in vitro. Then we assess the neutralizing activity of this plasma using lower concentration of type 1 interferon, which are more close to reality. And before we were stimulating the cells with 10 nanogram per ml of cytokine. Here we use a more physiological type 1 interferon concentration. And we could see that we went up to almost 15% of patients having neutralizing autoantibodies against type 1 interferon. So here we have the critical COVID-19 pneumonia, the patient with severe COVID-19, and some of the patients with mild COVID-19 also displays those autoantibodies. And most of the patients display neutralizing autoantibodies against interferon alpha or omega, but very few patients display neutralizing autoantibodies against interferon beta. And these results have been replicated worldwide, and there are over 40 studies showing the presence of neutralizing autoantibodies against type 1 interferon in patients with severe COVID-19 pneumonia. When we look at the risk of critical COVID-19 pneumonia, in individual carrying those neutralizing autoantibody, here you can see that the odds ratio goes up to 67 in patients having neutralizing autoantibodies against interferon alpha and omega and neutralizing high concentration of alpha or omega. But we can see that for the patient having neutralizing autoantibodies against alpha and omega, even neutralizing low concentration, the odds ratio to develop life-threatening COVID-19 pneumonia is pretty high. So then we assess the proportion of the percentage of patients with critical COVID-19 pneumonia who had those neutralizing autoantibodies against type 1 interferon. And you can see that this proportion among patients with critical COVID-19 pneumonia, you can see that this proportion increased with age, both in male and in female. So altogether, we show that this neutralizing, that autoantibodies against interferon alpha and or omega increase with age in patients with critical COVID-19 pneumonia. So there is and that this prevalence goes up to 20% in the individual over the age of 80. And when we looked at the patient who died following COVID-19 pneumonia, we found that approximately 20% of the patients who died of COVID-19 pneumonia had neutralizing autoantibodies against type 1 interferon independently of the age. So then we also assess the presence of neutralizing autoantibodies against type 1 interferon, but in children. So we recruited a cohort of almost 200 children unvaccinated who've been hospitalized for COVID-19 pneumonia. And here we find that approximately 10% of these children had neutralizing autoantibodies against type 1 interferons, and that the risk was again almost 70%. The odds ratio was almost 70% of developing severe disease when you had neutralizing autoantibodies, when you had autoantibodies neutralizing interferon alpha. And we also screened a cohort of over 2,000 children uninfected to look for the presence of these autoantibodies, and we could detect neutralizing autoantibodies against interferon alpha in approximately 0.2% of these children, and up to 2% of these children had neutralizing autoantibodies against interferon omega. We also assessed a cohort of almost 50 patients, 50 individuals, who develop hypoxemic COVID-19 pneumonia despite receiving 2 doses of mRNA vaccine, and they develop, hypoxemic pneumonia in between 2 weeks and 4 months after the vaccination. And here again, in about in about 25% of these patients, we detect neutralizing autoantibodies against type 1 interferon. And this, they develop this disease despite having neutralizing autoantibodies against SARS-CoV-2. So this means that these neutralizing autoantibodies against type 1 interferon can also be a risk of severe COVID-19 pneumonia in individuals who have been vaccinated, fully vaccinated with neutralizing antibodies against SARS-CoV-2. And last, we assess the prevalence of these autoantibodies in the general population. And we tested over 34,000 individuals from the general population, so pre-COVID. And we were wondering, do these people have neutralizing autoantibodies against type 1 interferon? And while we do detect, we can detect indeed neutralizing autoantibodies against type 1 interferon in the individual, and these titers varies in between 0.2% to 1%, depending on the concentration of type 1 interferon we are using. But we can see that this prevalence sharply increased after the age of 64 years to 65 years, and can goes up to 8% in the people after 80 years of age. So this suggests that approximately 100 million of people worldwide carry neutralizing autoantibodies against type 1 interferon and are potentially at high risk of developing COVID-19 pneumonia. And so, as I said, so these autoantibodies, we find them in approx 15% of the critical critical cases of COVID-19 pneumonia, in approx 20% of the fatal cases of COVID-19, whatever the age, and an APS1 patient who have, all of them have neutralizing autoantibodies against type 1 interferon are at high risk of developing COVID-19 pneumonia, and approx 45% of patients fully vaccinated can develop a breakthrough hypoxemic COVID-19 pneumonia because of these autoantibodies. So more recently, we tried to see if these autoantibodies could underlie other viral diseases, and indeed we detect them in a number of other viral diseases, such as critical influenza, MERS pneumonia, or some patients with herpes virus manifestation. And more recently, we also see that these autoantibodies are associated with an increased susceptibility to arboviral diseases. So first, we saw that approximately 40% of a small series of patients with adverse reaction to yellow fever vaccine, yellow fever live attenuated vaccine, approx 40% of the individual with adverse reaction had neutralizing autoantibodies against type 1 interferon. But we also recruited a cohort of patients with West Nile virus encephalitis and found that 40% of these patients had neutralizing autoantibodies against type 1 interferon. And if we look into the elderly, this goes up to 45% of the patients. We detect them in some patients with tick-borne encephalitis, and we recently could get some patients with severe arboviral disease caused by rare viruses. And in most cases, we tested with severe Powassan, Usutu, or Ross River virus diseases. Most of them had neutralizing autoantibodies against type 1 interferon. So now we are wondering if those autoantibodies can underlie other viral diseases or other disease unrelated to viruses. And as I said, they are present in the general population in between 0.2 and 2%, with a sharp increase after the age of 70 years. Where do come these autoantibodies? So that's the 1 million question. So we know that some patients with chronic exposure to type 1 interferon, such as patients with receiving recombinant type 1 interferon, do develop these autoantibodies. And we do find them in some autoimmune disease, such as lupus. There are a number of inborn errors of immunity, mainly affecting central T cell tolerance, which are associated with the development of these autoantibodies. As I said, APS1 patients for autoimmune polyendocrinopathy syndrome type 1 or APSET patients. So almost 100% of these patients have autoantibodies against type 1 interferon, but there are a number of other inborn errors of immunity, either affecting medullary thymic epithelial cells within the thymus or affecting T cells, again, often within the thymus. Many of these patients have neutralizing autoantibodies against type 1 interferon, suggesting that a number of patients can have that inborn errors of immunity can induce the production of these autoantibodies. And last, we know that patients with myasthenia gravis and thymoma with either thymic hyperplasia or neoplasia have neutralizing autoantibodies against type 1 interferon. So now we are searching for additional genetic defect related to the thymus or not, which could underlie the development of these autoantibodies. So in conclusion, 1 to 5% and up to 10% in children have with severe COVID-19 pneumonia carry inborn errors of type 1 interferon. But that the autoantibodies are neutralizing type 1 interferon are much more frequent, and we find them in 15% of adult patients with severe COVID-19 pneumonia, and we can find up to 20% of these patients over the age of 80 years with critical COVID-19 pneumonia can have neutralizing autoantibodies. They block the protective effect of type 1 interferon, and we showed this both in vitro and in vivo. We can find these autoantibodies against type 1 interferon both in the nasal, in the nasal mucosa. We found them also in the bronchoalveolar lavage, and we can find them in the CSF. They are present in the general population, so there are important clinical implications. So we need to diagnose the patient at risk of developing some severe viral diseases, so having those neutralizing autoantibodies. And recently, there was a paper published by Benjamin Hell in GXMed, who developed some sort of interferon 1 decoy, which mimics type 1 interferon. So, but this decoy type 1 interferon can bind to the can prevent the binding of this decoy. Actually, the autoantibodies against type 1 interferon can bind to this decoy, but they don't prevent type 1 interferon to act. So we found these autoantibodies in a number of other severe viral disease, especially in arboviruses. And so we're wondering if they can underlie other severe viral disease or other disease. And in some patients, they can have a genetic cause. So finally, I would like to thank the patient and the families who've contributed to these studies. Of course, the Lab of Human Genetics of Infectious Disease, Jean-Laurent Casanova and Laurent Abel, and especially within the autoantibody team, Paul Bastard, Adrien Gervais, Tom Levoyer, Jérémy Rosin, Quentin Philippot, Aurélie Chian et Emmanuel Jongui, and all our collaborators worldwide. We are more than 1,000 collaborators. Thank you for your attention.
Thank you, Anne, for highlighting that the presence of autoantibodies against type 1 interferon seems to be more prominent in certain groups of patients. Ursula.
Thank you very much. This was very interesting. In particular, I thought, apart from COVID, very interesting that also this is an issue when you have vaccination with live vaccines against, for instance, yellow fever, but I'm also thinking of the new vaccine against chikungunya now, and where we see that actually in the elderly, there is a high reactivity rate. So do you think it would make sense for these certain vaccines really to screen these risk populations, whether there are antibodies existing before vaccinating? Because I know that also against chikungunya, there are heavy, severe reactivity being shown.
I just apply for a grant to look at this. So it's something we plan to do, yes. So we are trying to recruit these kind of patients to search for these autoantibodies against type 1 interferon.
Yeah,
thank
very
you.
good point. Question in the back.
Yeah. Hello. Up here. Yeah, congratulations. I think this was very much discussed, and it's really great work. I actually have many questions, but I maybe want to pose three. Like, I have always been having trouble how to put this into context. Do you know of any antibodies against other cytokines? How common are they? Like, is it in the same range, or is this something special for interferon? That's one question.
Wait.
Okay, yeah, we can do it like this. Yeah,
So we are also looking for other autoantibodies against other cytokines. We haven't done that huge amount of study yet, but now we are trying to look at other cytokines. So there are a number of autoantibodies against cytokines. So I cut all my slides because I was so scared to be over time. So there are autoantibodies against other cytokines associated with other infectious disease. And there are a number of autoantibodies against cytokine which are present in the general population. So up to date, so we have much focused on autoantibodies against type 1 interferon, but hopefully or not, we will find against other cytokine, but we are not there yet, but
okay.
We're looking at.
Okay, interesting. And if I have some time, then also, well, maybe I cut this question, but you started, if I understand correctly, with the idea that you saw air deficient patient, you saw this, and I mean, you're the expert, as I suppose, in primary immunodeficiency. Is this related to maybe like the thymic involution in age or something? Do you have any?
So for air, air is a transcription factor which is involved in the thymic selection. But yes, in the elderly, one of our questions is they develop these autoantibodies maybe because of thymic involution or maybe because of thymoma, subclinical thymoma. This we don't know yet. So we're really looking into why elderly people develop those autoantibodies. I don't have any right answer yet. Many hypotheses, but not good answer yet. Thank you.
That relates to a question that we have from the chat, but Winfried first.
So wonderful talk. Thank you very much. I was wondering, you had it on your last slide, the possibility to make treatment with interferon beta, actually. So there are speculated forms of it. So would that be a way out to actually prevent vaccine hyperresponsiveness and also severe clinical cases that you just give them a jab of interferon beta?
So most of the patients do not have autoantibodies against beta. So it's why we were thinking of using recombinant interferon beta. It has been used in one patient and it was much better. So it improved the case. So, but then we have a number of issues. So if we go for interferon beta, we should give it very early. But now with this decoy receptor, with this decoy, so those interferon-like molecule, maybe that will be the way to go.
And there's a question from the chat, and the question is, might these autoantibodies just be physiological regulators of immune responses? And I would add to that, do you have any indication that these are cross-reactive with spike?
So we don't know. The second question, we don't know. And for the first one, it might be. So in patients with lupus, so it has been shown, it's study from Guy Goroshov in Paris, that patients who have these neutralizing autoantibodies have lower flare of disease. So they might be, in some condition, they might be helpful, yes. And maybe in the elderly also, if we have this type 1 interferonopathy, maybe they will be helpful.
So thank you very much. I think we really learned that we have to look at those autoantibodies. Thank you.